Hi, good evening.
Good evening. Welcome, Rajanas Kashara.
Hi, hi.
Hi.
Thank you. Very interesting topic, I think, today.
Yes, we will wait. All of the speakers, good presentations.
Yeah.
Hi, everybody.
Hi, Professor Konovalov. Thank you.
Hello.
Hi, Nikolai. Welcome.
Hello. Hello. How are you doing? Hello.
Good.
Is there any list of the names of the talks, or we just said the name and then we'll find the topic?
No. We have a line. Actually, first speaker will be Oscar, I think.
Yes. Yeah, I know. The name of the speakers, I know. I don't have the name of the talks. That's okay. So just. And
The
how
name
long
of
is
the talks are Oscar will talk on clinical and diagnostic challenges. Zhan Chen will talk on anterior surgical techniques. Dr. Nobuyuki Shimokawa will talk on posterior surgical techniques, and Mehdi Darmol will talk on complication avoidance.
Excellent. And how long it will be? 1 hour or more?
Each speaker will talk 15 minutes,
Okay.
and at the end of all, we can have discussion. Or
So
it depends. After each speaker, we can get questions.
So it will be no longer than 1 hour and a half, yes?
Probably in 1.5 hours we will finish.
Okay, yeah, because I need to correct my schedule.
Yeah, right. Exactly. We have 6 more minutes and then we can start.
Okay.
No. Mehdi, welcome. How are you? Dear Mehdi,
How are you, Professor Zilali? Thank you.
welcome.
Welcome. Thank you. Thank you very much.
Please unshare your screen because
Okay. I shared my screen.
okay. Thank you.
Okay.
Check.
Dr. Zanchen, welcome. How are you?
Hi.
How are you, Professor Zalagi?
Good to see
Nice to
you.
meet you.
And
Oscar, welcome.
Professor Oscar joined and Professor Kahraman joined, Sardar Kahraman.
Yes, we can.
Okay.
I think
Sardar,
that everybody,
welcome. How are you?
thank you very much.
Good to see you.
Good to see you too. I think we can wait for a couple of minutes.
Yes.
Okay.
Hi, it's Koto-san.
I want to say a few things. Actually, this is our 12th webinar on update of spine surgery. We are making every month such a webinar, and it's a very hot topic, management of OPLL. I will ask two moderators, Dr. Nikolai Konovalov and Dr. Serdar Kahraman, to invite speakers and moderate the session. Every speaker will have 15 minutes time, and after each speaker, we will get the answers to questions of the audience. Thank you all for joining us.
Oh, hello, everybody. Hi, we have to start, and the first speaker will be Oscar Alves. He is here. Oscar?
Yes, sure.
Yeah, hi. So your
Hi.
talk is the first one. You can share the screen.
Sure.
So we'll have 15 minutes talk, yes?
Yeah, okay. Okay, so thank you for Mehmet and for the invitation. You know, this is a joint session of MES, WFNS and IAS, and my topic is the clinical challenges of OPLL management. I have no disclosures for this presentation. And I identify as a surgeon 5 clinical challenges. And the first one is to diagnose OPLL. It's an enthesopathy that involves thickening and calcification of the PLL, which is different from a calcified disc annulus. And this leads to reduction of the canal, spinal cord compression, and neurodeficits. I don't know about your practice, but my practice, currently, most patients are evaluated with MRI only. So you need a high suspicion rate for OPLL, otherwise you will miss OPLL. You know, this is the example of this case. If you do a CT scan, you find completely surprised and you see an OPLL compressing the spinal cord. You can see it also on radiographs. There is low inter-observer reliability. So the CT offers the most sensitive diagnostic tool, and on the sagittal sequences, you can classify the types of OPLL. For example, this case here, very narrow canal, with CT scan, you show that the problem is much wider, so it's crucial for the selection of the appropriate surgical technique, as in this case here, you have to prolong probably the surgery higher up, which was not the case seen on the MRI. What's the incidence? It's more common in older people, male to female ratio 2.1, more common in East Asians. The prevalence changes in Japan, Korea, but always above 3%, 4%, less in Europe and US. But I would like to stress that the incidence is depending on the imaging method. And this very nice study done in 1,500 health Japanese people, it could be identified in 3% of plain radiography, but 6.3% on cervical CT. And if you apply CT, you get a much higher incidence than the ones that are published. So, and you have to look also for ossification in other regions, like thoracic regions. So OPLL cannot longer be viewed as a vestigial thing or pathology in non-Asian cohorts. If you have spinal cord injury with OPLL, it's 23% on this paper, but 88% of those patients had no bone injury, and the fall was the most important mechanism. So, and of those that sustained a spinal cord injury, only 25% were aware of OPLL, and most of them, half of them already had gait disturbance before the injury. So the prevalence of OPLL among spinal cord injury is alarmingly high, especially in patients without bone injury. This epidemiological study, which is the largest one done, showed that symptomatic OPLL, the mean JAW was 9, which is already quite severe. And the most common for indication was a JAW of 11. And this is too late. As you see here from Michael Felling's group, MJAW less than 15, it's a clear indication for surgical intervention. But you have to diagnose it before, because the chances of getting a good outcome relates to the pre-op MJAW. Using this clinical awareness model, diagnostic model using machine learning method, patients with cervical OPLL had poor postoperative recovery. So they worked on finding ways to early detect cervical OPLL, to timely program surgery and have better results. And it seems that with age, we already knew that, but body mass index were higher in OPLL. Main AST and urea also elevated, previous spine surgery, coronary heart disease, and if you see, anytime you see ossification of the anterior ligament, there is also a higher chance of OPLL. But of course, with widespread use of CT, there is an increasing number of patients that you discover OPLL incidentally. So these patients, they don't need to be anxious. Most radiographically detectable cases are asymptomatic, and the proportion in this study of the occupants of canal was 27%. And surgery is advocated if you have more than 46%. And again, from this study, we should not be offering prophylactic surgery, but educate patients for relevant symptoms and signs of myelopathy. The second challenge is that OPLL per se is an independent risk factor. In this study here, with 1,500 patients, the overall incidence of complications was slightly superior to 20%. Neurological deficits, 8.3, CSF leak, axial pain, implant complication. So there is a high incidence of surgical complications in OPLL patients compared with other forms of myelopathy. So consider the risk of surgical complications when you communicate with patients for decision making, and you should be alert for complications during and after the procedures. More operating time, more post-op drainage, CSF leakage, ischemia, reperfusion injury, also higher in OPLL patients. Dural tears, of course, high rate of CSF leak with OPLL surgeries, around slightly above 12%, which means you have dural ossification, that is the intimate adhesion of the dura to ossified PLL. And On this meta-analysis, if you look at the C5 policy, significantly higher on OPLL, although the AO spine shows that there are equivocal results that are higher in OPLL, but not significant. It seems that axial neck pain is the most frequent complication after surgery, and this is probably related with the number of posterior procedures being done, higher rate of superficial surgical site infection in OPLL. But there are also papers like this one saying that there is no difference in demographic, is in surgical approach, baseline myelopathy severity. The outcomes provided by surgery are the same, and the rate of neurological complications did not differ in OPLL patient versus all the others. So the third element is risk stratification among OPLL patients. Which one are the worst that we should be concerned? Appropriate classification is critical might be significant variations in neurological presentation, surgical outcomes, disease progression, and certain types of OPLL may be predictive of surgical complications. This is the Japanese Ministry of Health, Labor and Welfare classification. Basically have segmental, separate ossification behind the vertebral bodies. It can be early stage, but can be with very severe presentation, continuous type, mixed type, which is the common and usually severe, and localized, which is posterior to the disc space, and generally those are severe cases as well. You see one case of continuous, of segmental. Increased bone morphogenic protein expression was noted in continuous and mixed type. So they're probably also a pathological base on this radiological classification. It seems that myelopathic groups have more mixed and continuous, where asymptomatic patients more the segmental type. And mixed and continuous, they tend to produce a greater degree of canal stenosis. And risk of trauma-induced myelopathy also bigger in the mixed type. But there are many papers showing that this classification is not useful. There is no significant differences in upper or lower extremity function, urinary function. The pre-op JOAs were similar. The type of OPLL is not predicting of progressive myelopathy. Very interesting are those continuous bridging OPLL. You have to think that clinical myelopathy is a consequence of static and dynamic compression. And those patients with bridging OPLL, they have less motion, so they are less prone to myelopathy. Look at dural ossification. You have this isolated type, which is not related with OPLL, double layer, where there is some epidural space between the OPLL and the dural ossification, and the unblock, where all this is fused. And of course, the risk of injury is much higher with the unblock. And looking at double layer also, you have crescent type, short straight, long straight, and some authors claim that this can be related with the chance of developing myelopathy. Dural defects occur more prevalent with the non-segmental type. Of course, higher risk of CSF following anterior surgery, because it's technically difficult to separate the PLL from the dura. We should identify those high-risk patients, implement preventive measures, and even tell the patients that we might need to do techniques of dural repair. OPLL progression is a really big concern. More and more papers on the literature are reporting on that, which is by definition an increase in longitudinal extension of 2 millimeters on the thickness of 2 millimeters, or a new lesion, or bridging 2 or more existing lesions. And of course, this will cause further reduction of the canal. Involvement of C2, C3, C4 looks as a risk factor for progression of OPLL despite a laminoplasty. Also, younger patients and continuous type of OPLL are predictive of OPLL progression despite surgery. And on this very nice paper, if you look at different types of surgery, laminoplasty compared to laminectomy and fusion has much more progression of OPLL, and we should be aware of that and follow the patients. So concerning surgery, what's the time, what's the approach? This study with 480 patients, OPLL patients treated non-operatively, there was myelopathy progression in patients that were already myelopathic. So it means almost 50% of patients, but patients without myelopathy, only 16% progress into myelopathy. And Matsunaga already had shown that and predicted 71% myelopathy-free at 30 years old, 30 years follow-up. The canal stenosis is a more important risk factor for development of myelopathy, stenosis higher than 60 degrees. So again, prophylactic surgery is not recommended for patients without myelopathy. Conservative treatment is the situation. The risk of spinal cord injury is 0.2% per year. If you are a male, if you have OPLL and you are managed conservatively, there is an associated risk of a higher chance of spinal cord injury. With OPLL, 0.21% conservative treatment versus 0.37% for surgery. If you don't have OPLL, the risk is much lower. So surgery significantly lowers the risk of about 50% of myelopathy, progressive myelopathy in patients without OPLL. OPLL, this is the drama. Surgery via any approach is associated with higher rates of complications, surgical morbidity, and reoperate rate. Patients with myelopathy are advised to undergo surgery, and despite the increased morbidity with the surgery, compared with non-OPLL cases, it's still better to operate them than conservative treatment for symptomatic patients. Decompressive surgery is standard of care for symptomatic, and the MJOA classification will help us to identify patients and select patients for surgery, MJOA less than 15. There is still a lack of consensus on timing and choice of surgical approach, and as we know, time is crucial. When you think about an approach in the setting of degenerative cervical myelopathy, OPLL itself is a modifier for selection of type of surgery. We have here an oxymoron, a paradox, which is the anterior approach, the one that tackles the compression. It's the most effective in terms of neurological improvement, but it's also the most risky, most associated with neuroinjury and dural tears. Posterior approach is lower complications, but a low disease progression. So this is the trade, and new surgical treatments can aim to reduce these complications, and I think next speakers will approach this topic. As you see here, anterior approach is better post-op JOA and neurorecovered laminoplasty, especially true if the space-occupying lesion more than 60% of the canal. The OPLL, the K-line is a very important concept, which is this straight line that connects the middle points of canal C2 and C7. The OPLL crosses the K-line, it's considered negative K-line. And generally speaking, patients with positive K-line, they tend to have a higher recovery rate and better postoperative JOAs. You can have a negative K-line because you have a kyphosis or you have a thick ossification, like on this case here. Patients with pre-op kyphotic alignment have better recovery with anterior approaches. Also, K-line negative, and this is a cohort of just patients with K-line negative, and they do much better with an anterior approach. With laminectomies, laminoplasties, you have a progressive loss of lordosis, and we are now looking at new data, new criteria for decision-making, and this very nice paper shows that high pre-op cervical SVA, there is high probability of sagittal imbalance and neurological symptoms with laminoplasty. So this is the kind of algorithm that I choose, less than 2-level anterior approach, more than 3-level. I will go posterior, looking at the space for the core, the occupation ratio, more than 60%, the K-line. If K-line is positive, no neck pain, laminoplasty, neck pain, fusion. If the K-line is negative with kyphosis, let's look at if it is flexible or not. And if not flexible, we need a 360 approach, or if it is flexible, we can go from the back. So just to show one of my cases, two-level compression, high canal occupying ratio, not important. It's almost a straight spine, K-line negative, pre-op neck pain, and I did an anterior surgery. So what are the clinical challenges? OPLL is best diagnosed using CT imaging, but you need a high suspicion rate to prescribe a CT. like that you avoid underdiagnosed or mistaken for milder forms of degenerative calcification, which is a different disease. OPLL is an independent risk factor for myelopathy progression and worse surgical results. That's why it's important to diagnose it. From the literature, there is still a lack of standardized and reliable classification system to stratify the patients and predict natural history management of OPLL outcomes related to the various interventions that we do. Thus, it's essential to identify patients at high risk of OPLL progression and implement appropriate preventive surgical strategies and regularly monitor those patients after surgery. And optimal time and approach of surgical intervention still controversial. Thank you.
Thank you very much, Oscar. It's a very interesting presentation, very important. Do I have special chat for the questions?